Thank you, Chairman, for your nice introduction. I'm Joon Kim from Ulsan Medical Center. I'm a vascular neurologist and usually treating patients with ischemic stroke. So I'll just start with the stroke. Stroke is a disease of various mechanisms, and a considerable portion of patients are caused by the large arterial atherosclerosis, which is predominantly in the carotid artery, and in Asians we do have many intracranial atherosclerosis. The mechanism is more detailed by subdividing it to artery-to-artery embolism, inside to thrombosis, hemodynamic strokes, and in the case of intracranial atherosclerosis, we do also have some local branch occlusions. So why is the mechanism important is the treatment of stroke prevention is associated with the mechanisms. And these days we do use antiplatelets, anticoagulants, and risk factor controls, and also some procedures related to decreasing the secondary stroke. And maybe those will be dealt in the following lectures. So more in a detail, you can see here that the proximal ICA disease is mostly associated with the artery-to-artery embolism. Most of the stroke is caused by the platelet aggregation activated in the carotid artery area and embolizes distal to the brain. However, in the case of ICAS, intracranial atherosclerosis, it is related with more various mechanisms. So in the case of carotid artery disease, a very potent antiplatelet treatment can be beneficial for reducing the secondary stroke or even in the primary prevention era. Actually, what we found is the location of atherosclerosis differs according to the vessel morphology. If the ICA and ECA has a more wider bifurcation, there is a second angle in the apical area, more distal to the bifurcation area, and that can cause another atherosclerosis in the inner curvature of the ICA. However, usually the atherosclerosis is developed in the bulb area where the bifurcation is. And because of the bifurcation, it can cause turbulence in the outer wall area, which results in a low shear stress area, and that can cause the development of atherosclerosis. So these are called the apical atherosclerosis, and these are called the lower body type atherosclerosis. Why this is important is the nature of the stroke is slightly different according to the location of atherosclerosis. If there is an atherosclerosis in the apical area, the bulb area remains, and there can be a turbulence inside this area, which can cause a very low shear stress area, and resulting in a larger thrombi, just as in the left atrial appendage when there is an atrial fibrillation. So in this case, the stagnation causes a larger thrombus, which distally embolizes and causes a larger infarction. In the case of the body type atherosclerosis, there is no much recirculating zone. There are a very small recirculating zone in the distal part of the atherosclerosis and a very high flow blood flow flowing through the stenotic area, and that can cause the platelet aggregation in very small emboli and resulting in small infarctions. However, the most important factor that is related with the stroke is the presence of symptomatic ICA disease. The asymptomatic carotid artery disease is a totally different disease to the symptomatic ones. And the second way may be important is the degree of the stenosis, showing that the highest stroke risk in those who have a near 80 to 90% of stenosis. As it passes to the 95 and more higher stenotic degree, the flow rate decreases and the stroke risk also decreases with the stenosis degree. So how can we measure the stenosis degree? There are MRA, CTA, and conventional and angiography. These are very good at looking at the location of the atherosclerosis and the length of the atherosclerosis. And also we can see the full length that if there is a tandem lesion in the vasculature. However, we can't see the vessel pathology itself, and therefore the duplex carotid sono is very important and complementary that we can see the nature of the stenosis, for example, atherosclerosis or the high-risk plaque. Also, we can measure the stenosis degree in a quantitative manner, and we can see if how much the stenosis it actually is. But we have to consider the two criteria, which is the diameter reduction and the flow velocity. If the diameter reduction can be different according to the insonation angle. So in the extreme case, you can see this can be measured at a 60% stenosis by this insonation angle. But in the case like this, there may be no stenosis. So looking at the diameter reduction together with the flow velocity is important. However, when you use the flow velocity only, if there is a contralateral stenosis or occlusion, the flow itself is increased to the ipsilateral area. So the stenosis may be overestimated. So using these two criteria together is very important. We also use IMT and measured by a standard method. It is usually measured in the common carotid artery rather than the internal carotid artery because the common carotid artery has a lesser tortuosity or a lesser morphological change. So it can we can more obtain the systemic factors which is related with the atherosclerosis in the CCA. ICA can be more influenced by the local turbulence according to the morphology of the vessel. So the IMT shows that it is related with the cardiovascular disease. However, it is also related with myocardial infarction, and also with a stroke. But it reflects more the general atherosclerotic burden, but not specific for the stroke patients. So for the symptomatic carotid artery disease, MRI and CTA is important looking at the stenosis location and the length and the presence of a tandem lesion. However, duplex can be important when we want to look at the stenosis, cause of the stenosis, the etiology, and also the quantitative measurement of how much the stenosis is. TFC is also some benefit looking at the collaterals. So if there is some collateral through the leptomeninx or from the Willis circle, it can be evaluated well by the TFCA. And I would like to more talk about the asymptomatic stenosis because it can be also important in preventing a stroke before it occurs. So the prevalence of asymptomatic carotid disease is not uncommon. If we look at the patient, the incidence of moderate stenosis, which can be defined by more than 50%, it goes up to about 8% in the more than 80s in the male patients. So these days, the duplex is well used in screening these patients. When we go to the severe stenosis, which may need another treatment modality, it also increases to 3% in the 80s in the male patients. And what influences the prevalence of these kind of carotid artery disease? It is more common in the Caucasian population, and also it is more prevalent in those who have a higher atherosclerosis burden in the coronary artery disease. So if the patient have a coronary artery disease, maybe screening for an asymptomatic carotid disease can be a very nice strategy. However, the risk of stroke in asymptomatic stenosis is quite different from the symptomatic ones. As you can see here, the annual risk of the asymptomatic carotid artery disease is now under 1.5%, and it is continuously decreasing as the medication, including statins, are getting developed, and it is more improving and improving. So when we approach for asymptomatic ICA disease, we should have a different strategy, and also we have to look at which patient has a real high risk. So is all asymptomatic ICA stenosis really asymptomatic, and how can we judge if there is a high risk plaque or not? So when we look at the data regarding the incidence of stroke in these kind of asymptomatic carotid disease, the annual risk for those who do not have a high risk, the low risk group, is only lower than 1% annually. However, if there is a high risk feature, which I'll mention in the following lecture, the stroke risk goes up to about 4 to 5% in those who have a high risk plaque nature. So the risk of infarction can be increased up to several times higher in those who have a high risk plaque in the carotid artery. And how can we define the high risk, and how can we evaluate these carotid artery disease? First, I would like to mention that if there is a echolucent plaque, which represents a large lipid core, those patients may have a higher risk of ischemic stroke. As you can see here, if there is an echolucent stroke, echolucent plaque, from the ACST1 trial, the risk of ischemic stroke increases 2.5 times higher than those who do not have an echolucent plaque. And from some meta-analysis, you can see the risk increases similarly about 2 times in those who have echolucent plaque. And if you restrict this to 50% of carotid stenosis, which is significant stenosis, the risk goes up to 2.6. So if the patient have a echolucent large lipid core, it can be a high-risk plaque, even though it was asymptomatic. How about a plaque ulcer? It can represent former plaque rupture with a distal embolization, but also we can show, when we look at the hemodynamics inside the ulcer, there is an area with a high shear stress which can activate the platelets to make a thrombi and distal embolism. So if there is a plaque ulcer, it also increases the risk of further stroke. And you can see here, if there is more and more ulcers, if the number increases, there is a dose-dependent relationship between the number of the ulcers and the risk of embolic stroke. And how much is the risk? You can see here, if there's more than 3 ulcers, it is very similar to that those patients who have a microembolic signal from the transcranial Doppler, which represents a very high-risk plaque. The plaque ulcer also, the location is also important. And if you can divide the ulcer to the stenosis, the location of the ulcer proximal to the stenotic area, and also to the distal to the stenotic area, the patient who have a distal ulcer shows a more high risk. So if there is a stenosis and if there is a distal area ulcer, that can increase the risk of ischemic stroke by 2 to 3 times higher than those who do not have, to those who have a proximal ulcer. The neuroimaging and imaging technique is more and more getting developed, and nowadays we use some high-resolution MRI, which quite correlates well with the pathology from the obtained from the carotid endarterectomy. And from that, those kind of data, we can look more frequently and find frequently the intraplaque hemorrhage. If there is intraplaque hemorrhage, it is a very high-risk plaque. And among those with asymptomatic patients, if there is an intraplaque hemorrhage, the risk of ischemic stroke increases about 8 times than those who do not have an intraplaque hemorrhage. And this can be also a promising imaging marker for evaluating the high-risk plaque in asymptomatic patients. So if we have a suspect, how do we investigate if he's a true suspect or is a high risk to have another crime? Well, actually, we can look at the criminal itself, which is investigating the criminal, and we can also go to the crime scene. In this case, in the case of ischemic stroke, the crime scene may be the brain. In the brain, we can look if there are what the lesion pattern is, or if there is a lesion or not. And also we can monitor the TCD, if there is microembolic signals, which are showing continuously the emboli is going to the brain. So I would first talk about the silent brain infarctions. There are some cortical silent brain infarction which we can find from the health checkups, and the rate of silent brain infarction is not so low. If you look here, if the patient have a ipsilateral carotid stenosis more than 50%, you can see that there are about 15% of the patient may show a silent brain infarction. And also you can see a dose-dependent manner between the stenosis degree and the number of silent brain infarctions. So if the patient have a more stenotic vessel, the patient may have a higher chance to have a silent brain infarction. If the patient have a silent brain infarction, he may have another stroke in the future. Looking here, if there is no silent brain infarction based on the CT, the patient only may have 8%, annually 1% of stroke rate in asymptomatic cases. However, if the patient have a silent brain infarction detected on CT, you can see the annual risk goes up to 3.6% per year. And this also shows some kind of dose-dependent effect if there is more and more embolic pattern of infarctions in the CT. This kind of silent brain infarction also shows that it is related with the risk of stroke after the CEA. And if the patient has a silent brain infarction, the patient may have a 4 times higher risk of stroke even after the carotid endarterectomy. A more direct method to monitor is the microembolic signal detected by the transcranial Doppler. As you can see here, if the patient has an MES, the patient has a higher risk to have an ischemic stroke. And how much risk is that? You can see here if they're using the patient who don't have an MES as a reference, if there is a microembolic signal detected by the transcranial Doppler, these patients may have a 5 to 6 times higher risk of ischemic stroke. And from the meta-analysis, if the patient have a microembolic signal detected in the transcranial Doppler, the patient may have a 7 times higher risk of ischemic stroke and a 12 times higher risk of ipsilateral stroke or TIA. This is a very powerful predictor for predicting the further stroke in the future. How much patients among asymptomatic carotid stenosis have these kind of high-risk features? Well, about 1 of the 4 patients who have asymptomatic carotid stenosis may have these kind of high-risk feature of high-risk plaque. So it may be important to look at if they have these kind of features or not. Well, how much risk do they, how frequent are they? Well, echolucency plaque is most frequent. Some patients have ipsilateral silent brain infarction. Less than them, they have microembolic signal. And some may have an ulceration in the plaque. How many relative risk is caused by this? Well, actually, if there is a microembolic signal, you can see the odd ratio is most higher. And if the patient have a echolucent plaque, the risk may go up to 2 to 2.5 times higher than those who do not have echolucency plaque. Another thing is the progression of the atherosclerosis. About 10 to 30% of the patient may have a progression when they are followed by the carotid duplex. And if they have a progression, they may have a higher risk of ischemic stroke. So duplex may have some benefit when they are follow-up, and because they don't use the radiation hazard or they don't use the contrast, it can be a very safe and efficient method to follow up the carotid disease. So if there is a progression, we may need more aggressive treatment for those patients. For the last 2 minutes, I'd like to show some data about the vertebral artery. According to our data, when we have performed stenting, the instant restenosis rate and the rate of ischemic stroke was much more higher in those who received the vertebral basilar system. So even after stenting, I think the management for the vertebral artery disease should be much more aggressive regarding the lipid lowering or the antiplatelet agents. When we use a duplex, when we just correct the insonation angle to the posterior area, we can see the vertebral artery between the spinous process of the vertebra, and the flow rate can be measured. Though there aren't no actual cutoff value for the flow velocity or the stenosis degree, still it can be useful to observe the real-time flow in the vertebral artery. Because sometimes we can see the reversed flow in the vertebral artery. In that case, those patients may have some subclavian stenosis, resulting in the subclavian still a reverse flow from the vertebral artery to the brachial artery. It can be provoked by the hyperemia test using the blood pressure cuff. So if you use those kind of hyperemia test, actually the anterograde flow can be completely reversed using the hyperemia test, and maybe these patients may need further evaluation. Also, some patients suffer from having dizziness when they make a turn in their neck, and that can be caused by the Bowman syndrome if there is a unilateral occlusion of the vertebral artery, and when you turn your neck, another vertebral artery can be compressed, and the flow can be absent, and that can cause some kind of dizziness. So as mentioned before, the ICA carotid disease is an important cause of stroke. We may evaluate by MRA, CTA, TFCA, and also by duplex, and they may be very complementary. Asymptomatic ICA disease is a totally different disease, but still needs attention because some of those patients may have an ischemic stroke. Therefore, we need to look at the presence of high-risk plaque, which is defined by the echolucency, presence of ulcer, and also some microembolic signal detected by the TCD, and also from the silent brain infarction observed from the MRI. Maybe the comprehensive evaluation using various modalities may be helpful for the patients. Thank you for your attention.